More than two-thirds of adults living with a mental health problem report first seeing symptoms in their youth. This is just one of the reasons that the provincial government launched the first phase of its mental health strategy with a focus on child and youth mental health. That was done in 2011. Joining us now to examine the strategy's successes and stumbles, here are Kimberly Moran, President and CEO of Children's Mental Health Ontario; Mark Campbell, Executive Director of Delisle Youth Services, that's a Toronto Children's Mental Health and Complex Special Needs Program; and Lori Spadorcia, Vice President of Communications and Partnerships at CAMH, the Centre for Addiction and Mental Health. Good to have you three here at our studio today for this discussion. We want to remind those of you watching you can be part of this conversation. Producers are hosting a Twitter chat right now, so chime in with your views and use the hashtag AgendaTVO. Okay, let's review this. The past 3 years, the mental health strategy has been focused on improving children's mental health in the overall scheme of things. Are there signs of success? Kimberly, you first.
Yes, I think the government's made some quite smart investments. I think that the telemental health has yielded benefits in the north and in rural areas. I think that Lori's work on collaboratives is, established some platforms, and she can talk about that. I think that School Mental Health Assist, which is around educating administrators and teachers around mental health issues and getting their knowledge up, is really smart. And I think that the mental health workers that have gone into schools and into some community agencies like Mark's has, for kids who need a couple of sessions of counseling, have really made a difference. So yes, I do think that there has been some smart investments.
Lori, you want to follow up?
Sure, yeah. So I think, one of the biggest challenges, of course, in the mental health system is that we've got a relatively fragmented, uncoordinated system. And the work that we tried to do in the first 3 years of the strategy was to really make those important linkages. So at CAMH, the service collaboratives, which Kim mentioned, was really building a platform for agencies to work together so that we could create the appropriate pathways to care for children and youth.
Just, there will be some jargon in this program, but we're going to try and translate. Service collaboratives means?
It basically is a network of agencies, local agencies, and the driving force is really to bring different people together. So at these tables, we've got police, we've got school boards, we've got hospitals, we've got children's community agencies, and the magic of it was really having all these people sitting together and saying, what can we do together? How do we identify what's going on in this community? Where are the gaps? And what can we as a collaborative do together to fill those gaps?
Okay, Mark, what would you add to that?
Well, I think building on what Lori's saying, it's true. A big part of what the government's asked us to do is change our conversations and change some behaviors so we work together across sectors. And that takes different processes. It takes a lot of work, a lot of time, and as you say, creating those relationships to help us change how we work together. Because I think that's what happens as parents end up with fragmented pieces as they search for help for their kids.
Here's how the Ministry of Health and Long-Term Care answers the question when you ask what signs of success are there out there. Sheldon, shall we bring this up and we'll go through this list? They say that more than 50,000 additional children and youth are receiving services. More than 700 new mental health workers have been hired in communities, schools, and courts. More than 1,000 post-secondary students a month are using a province-wide helpline. More than 2,500 additional psychiatric consultations are happening per year through, as mentioned, the Telemental Health Service for remote and underserved regions. That 14 out of 34 lead agencies have been identified, plus the remaining 20 to be announced in 2015 as part of the Moving on Mental Health Plan, and 18, as you described them, Lori, service collaboratives have been launched. Okay, let's go through these and just make sure we have a better understanding of what they all do. Kim, this telemental health service, how does that work?
Well, if you need a psychiatric consultation and you're in the north or in rural areas, often there's not child psychiatrists available. There's only 109 child psychiatrists in the province itself. So what that does is that it allows for using technology so that a child can get the proper psychiatric assessment.
They make a phone call?
Well, it's video conferencing, actually.
Video conferencing?
Yes.
Okay. And, I mean, it's one thing to call up, telehealth and say, my kid's running a temperature of 102, what do I do? this is obviously more complicated. How does it work?
It is more complicated, but they've set up this platform so that it actually is fairly friendly for kids, and it's usually done with an agency like Mark's that's sitting in sort of rural or northern areas, and there's staff around the child and the family, so that they've developed a level of expertise to deliver these types of services. So it really is something that makes a lot of sense. A funny thing is that you can actually get telepsychiatry consultations faster than you can get face-to-face psychiatric consultations in Toronto.
And are they effective, though?
They are. There's research has shown that it is effective. Lori, do you have any more information on that?
I don't have the research in front of me, but you're right. We are finding that the face-to-face, mental health is a different kind of field than physical health, in that you don't have to touch the patient. So, being in a teleconference scenario, can really benefit. And the other thing that telepsychiatry can do is help connect experts to health professionals. So how do we build capacity across the province so that people in family health teams or in community agencies can have access to experts in different parts of the province?
Mark?
Well, I was going to say that's exactly how we use psychiatry ourselves in our organizations. Is we often get the consultation, but it's actually our social workers and our child and youth workers who are the people day to day making those differences with our children and our families. So often the psychiatrist is able to, if there's medication issues, they can help us look at those kinds of issues, but it's not that often that they're doing the one-to-one counseling. It's our staff, but we want to have that consultation to make sure we're in the right direction, doing the right modality of treatment.
Okay, you folks are in the system, so you see these improvements in place. Do parents and children, Kim, actually see these in place?
I would say not yet, not on the ground. Certainly, these are very structural changes that are happening, and they're important changes. But if you're a child or family on the ground, you're actually seeing a great deal of wait times. You're sitting on wait lists for services. Certainly the 1 or 2 session type of work has sped up a bit. But if you're looking for anything more than a couple of sessions, you're often sitting in wait times from 3 months to over a year.
This is not an academic exercise for you and your family, is it?
No, it isn't.
You want to share a bit about it?
Absolutely. My daughter became ill when she was 11. She said one day that she was sad. And like any diligent parent, we went to school and to her friends and home and looked, and there was really nothing there. And went to then our family physician looking for help. They referred us, but we had wait lists and wait times of up to a year to get some assistance. And so, of course, while we waited, she deteriorated very rapidly, and within a couple of months, we ended up in an emergency room because she was suicidal. Hard to believe at 11.
11?
Yes, at 11 she was suicidal. And so then we ended up entering the system where she had to go into a hospital setting for almost 6 months of care because we couldn't get services when we needed them. And then 18 months more of intensive service after that. So from a taxpayer's point of view, not a great thing to happen, because that's expensive when their kids are getting these intensive type services in hospitals and in intensive treatment situations. And from a family's perspective, you can imagine how hard it is on a family to support a kid through that. And for our daughter herself, she missed just over 2 years of school and friends and growing up that she can't get back. Now,
So she's 13 now?
she's 14 actually,
14?
and she's in regular public school, I'm happy to say, and doing quite well. She has an anxiety disorder, we found out, and obsessive compulsive disorder, so she needs support for those things. And as a family, we needed to get supports as to how to look after her.
Does the story, well, I was going to say, does the story have a happy ending? I guess you don't know yet, but is it on the way to having a happy ending?
It does have a happy ending. I think that for all intents and purposes, if you met our daughter today, you would say, oh, she's a perfectly normal, happy girl. I think that it does have a happy ending. I think that she has a chronic illness, though, and she will need those kind of supports, for a very long time, I would expect. But the difference, I think, with this chronic illness is, if you can imagine it was a physical illness, if we had to wait for treatment for 2 years, that would never happen.
Right.
So I think that's the part that sort of motivates me, that things have to change in this sector, because it shouldn't be different for a child who is mentally ill.
How typical is this story, Mark?
Way too typical.
It is, eh?
And our distress is that, in fact, we know mental health is like illness is the same as any other illness. The sooner you intervene, that's what Kim says, the sooner you intervene, the better chance you have of helping people develop the skills and tools so that we don't end up in the emergency rooms, we don't end up in hospital. And it doesn't guarantee it completely, but we can build in a lot of tools, and we do that all the time with youth. That's the frustration of the work, is the wanting to be able to do more earlier when you know, because it's at age 9 is a normal time for anxiety to start exhibiting itself, and adolescence for depression. Those are the reasons kids come to us.
She lives in Toronto. Can I assume, Laurie, that if you're trying to get any service in more remote areas, it's even harder?
Well, absolutely. I mean, there's a special problem in remote areas, and that is the lack of health resources there. We're doing well with the expansion of telepsychiatry and trying to reach out into these areas. But again, it's about making the right linkages. And I would say that, there are some communities, for instance, like First Nations communities in very remote areas, where we can go in and provide some care, but then you really need to think about the impact of the social determinants of health on people. So,
but I think people
good
would be
housing.
shocked that if you live in Toronto, which is, I mean, it's one of the best served catchment areas anywhere in the world, you would think, for health services, waiting a year for psychiatric services in Toronto?
It's
really?
true. Yes. And it has a lot to do, what we learned in the collaborative process is it really has a lot to do with different systems speaking with each other. And, I would say the theme was about transitions, and it was the gaps in transition between age groups. It was the gaps in transitions between hospitals and community care. It was the gaps in transitions between schools, elementary to high school to university.
So
these are all critical points.
Working on fixing these gaps?
We're trying to.
Kimberly, you wanted to add?
Yeah, and I think perversely, some of the great policy work that's happened and the programs that have happened, like School Mental Health Assist, has actually increased demand into the sector. So as we've educated administrators and teachers to say, Johnny, who's maybe aggressive in class or showing some behavioral issues, well, maybe he's not a bad kid from a bad family. Maybe he's got mental health issues. Now they're being referred into the community-based children's mental health treatment centers and facing even longer wait times. So
because the demand is growing.
That's
Yes,
right.
exactly.
So I think that we have problems that have to be dealt with just by additional funding as well because of demand.
Can you, Mark, talk to us about, because I want to get through this list of things here, moving on the mental health plan. What is that?
Moving on?
Yeah.
Well, it is part of those processes the government talks about, and whether the lead agencies, because they really, to their credit, recognize that families really do want and need a central point in order to access service.
And who is that?
Who is
What's
that?
the central point?
Well, you mentioned the lead agencies that they talk about, so that's going to be the lead agency. We don't have the exact definition. We know there's going to be some branding to this, but we understand that there's going to be a lead agency where parents and doctors and all the people who need to make a referral to children's mental health will be able to call. And so that will be announced in Toronto between January and March, is my understanding.
And when it all is up and staffed and in place and resourced appropriately, one hopes, how's life going to be different for people?
Well, one assumes, and I do actually, I can tell you most children's mental health agencies do support this concept, because we do know families really talk about their distress of trying to find us. So it will be hopefully a better access way, and parents can phone that organization and know that that they'll be told about Delisle Youth Services or East Metro or any other service across the city in terms of where they might access that support and how to get that. Challenges? The challenges is that there's not, like, we have these wait lists already. So you will know where the door is, you will know how to get through it. The challenge will be, will the service be available in a timely manner?
Let me pick that apart a bit. When you needed access to mental health services for your daughter, using the metaphor here of a door, did you know what door to enter in order to find all of that?
No, it was very difficult to find the door, and the doors that we did enter finally, and I'm a resourceful person, so we looked very hard for that, then had these long wait times. So I think, as Mark says, to build off that, absolutely we think that these structural changes in the children's mental health sector are important. They're valuable. They may take 3 to 10 years where we really see the fruit of them, though. And then the real issue is that, you know, when you get through these doors, that then you face huge wait times. And you know, our daughter certainly deteriorated within a couple of months. So kids can't wait. And you know, if you really stand back and say, as a taxpayer, where do you want your money invested? It would make a whole lot more sense to have children access service right away than end up in expensive emergency rooms and in our acute care system.
What's that old commercial, the old tagline? You can pay me now or you can pay me later?
Exactly.
Pay me later, it's always more expensive. Lori, let me delicately raise this issue here because there seem to be two schools of thought. One is that we're seeing more demand for these psychiatric services because people are more aware of their rights, they're more aware of mental health issues and so on, and that's all to the good. On the other hand, I have heard people say things like, you know, they're medicalizing everything right now, and, you know, two kids get in a fight in the schoolyard, and immediately some mental health professional is going to be out there saying, oh, well, of course, they've got X, Y, and Z. Any concerns that if we train school staff to have a better understanding and appreciation of mental health issues, that we're going to be creating other problems that didn't exist before? You know what I'm saying?
I know what you're saying, but I can't say that we're concerned about that. I think, you know, as Mark said, you know, what we know about mental illness is that if we can identify it early and intervene early, that we can, you know, we can basically change the trajectory of the illness. It's not always going to be an illness, you know, necessarily, but we need to know if every door is going to be the right door. We need to be able to, in all of those different agencies and in all of those different aspects of life, be able to have people recognize where there are problems. Maybe they're behavioral problems. Maybe, you know, maybe they need the help of a hospital. Maybe they don't. But we need to be able to see what it is that's necessary.
Mark, you want to add to that?
Well, I think I don't worry about it, Steve, because in fact, the rate we know it's actually the #1 illness in childhood, 1 in 5, and we know only what's
1 in 6. Only 1 in 6 children get treatment.
Yeah, 1 in 6 get the treatment.
1 in 6
get treatment.
Get treated. Who need it?
Who need it. So I think there's always that issue, there's always that conversation, but we also have skilled clinicians. We actually have tools that when we do intakes and we're talking to people, we sort out pretty quickly, you know, is this really a big issue, or is this, you know, we do triage, we figure out if we got a suicidal youth in front of us, or do we have someone who has some school anxiety and we can do different interventions. It's not just a come on in, we'll label you and
Gotcha.
Pull up the couch.
Kimberly, what about family docs? Do they have the adequate training to recognize mental health issues in young children or teenagers that they need?
Generally, in medical school, they get very little children's mental health training. And in children, mental health issues often present a bit differently, so it is a very specific skill. It is something that the government is got to pay attention to as well, so that they can be, that at primary care level, they can be a better front end to the system, so they can do some work at that side as well. So it is very important, but I think that, you know, just establishing, you know, the connections between primary care physicians and children's mental health treatment centers would be just a big step that we could achieve more quickly than educating all the family physicians.
Mark, I do want to follow up, though, on that example I gave a second ago, and that we don't want to scare parents into thinking that every time their kid comes home from school having gotten into a fight or, you know, lost their temper or something like that, that suddenly, you know, there are mental health issues at play here.
Exactly.
How are parents supposed to tell the difference?
Well, parents, you know, I think, I mean, again, there's lots of conversations here, but I think really when you have parents, it's knowing, is this an ongoing issue or is this once? You know, a way of thinking about it is, you know, checking in. I'm sad, but they didn't say I'm sad once, and they couldn't name what they were sad. Kim's daughter couldn't say what she was sad about, and it was getting worse. It's just like any other illness, you know. Is this sort of a one moment, or is this an ongoing issue that isn't going away, and with any number of interventions, it's not changing?
Okay. The Minister of Health and Long-Term Care for the province of Ontario is a guy named Dr. Eric Hoskins. Let's play a clip of him on these issues. Roll tape, please.
Today I'm announcing the second phase an important expansion of our strategy that will help us improve access to services, will objectively reduce wait times, and close the gaps that remain in our system, especially when it comes to, as was mentioned earlier, especially when it comes to transitioning between adolescence and adulthood. It's an extremely complicated moment in time, or a transitional period, and we need to do a better job as government in terms of the services that we provide to accommodate that transition and to make sure that the services being provided genuinely are having a positive outcome and helping young people transition through that very challenging time. Challenging, again, for any of us, even more so when we're talking about individuals that have mental health or addictions challenges.
Laurie, let's just understand what's so significant about this transition period from adolescence to adulthood. The minister said it's a very complicated period. It's hard to create services designed for this particular period of someone's life. How come?
So I'd say there's two issues here. One, it is a complicated time in a person's life. There are lots of changes. So, someone who has some mental disorders would find those changes to be even more difficult to deal with, and we need to make sure that the right supports are there. On the other side of it, though, everybody's funded. It really is that it takes a village kind of attitude. All of these different agencies and different branches of really different government departments are funded differently, and there's different age cutoffs. So, you can walk into one agency and they'll say, we'll accept youth the age of 18 to 24, another 16 to 18. You've got people dropping off at different points, and we don't have a way of capturing those people who are basically, they're being given a service based on the fact that the agency's got a cutoff.
Can the government of Ontario not just say, okay, everybody, all you agencies out there, all our ministries in here, when we talk about services for young people, we are talking up into the age of, make it up, whatever, 21. After 21, you're an adult. Before 21, you're us. Can't they do that?
Well, they could, but we also need a little bit more flexibility on sort of just assigning a specific cutoff.
But then if everybody's got different age, if everybody's got a different age category that they cover, well, that's not my responsibility. That's over here. That is part of the. I mean, you can play one off against the other here, can't you?
Right, but why not just follow the patient and and just focus on the fact that no matter what age they are, they need to have services at that age. And so how can we, I think the government could do well in sort of instructing, their other government departments to all work together and just say, okay, here's how we're going to follow this patient. This patient needs this service at this point in their time, and they're going to be eligible for it.
That makes too much sense. So that'll probably never happen, right? Just follow the patient, right?
It doesn't, because ministries do have some very clear rules, Steve. And Ministry of Children and Youth Services up to 18. But in fact, if you think about how many adult children are living with parents right now, it doesn't actually work. That's an old number for adolescents.
Obamacare, you're a kid till you're 25. Right?
Exactly. So there's a lot of pieces, and as Laurie said, the sense of following the patient and connecting, doing more warm handoffs into adult services, because they're very different processes and very different structures. There's a lot of thought that actually has to go into those pieces. So if we follow the patient and work together, that can make some big things. And we need some flexibility. It's kind of ironic. We like to have programs because we can create structures and understanding, but if we don't have flexibility, then it's very hard to just do what the patient needs versus what the program services need.
Okay, so Kimberly, your daughter's 14 now, right?
She is.
Okay, so I would assume that comes under the rubric of Children's Youth Services. She's still... Now, she will be presumably going through some kind of transition to adult treatment at some point.
That's right.
Everybody got all this figured out?
No, I think the government really needs to take a good look at this and look at their whole sort of policy umbrella around this area, because it really has to be a concerted handoff and a concerted policy around getting kids from the children's sector to the adult health sector.
Have you dealt with any transitions yet yourself?
No, but I have with other parents that I talk to. You can imagine that many parents will come to me and looking for advice, and certainly it is very important. Parents have to become these strong advocates for children, but it's tough because at 18, actually from a legal perspective, you don't get access to your children's information, and so that age of consent issue often becomes a bit of a barrier in there for families to advocate for their children. And often children who struggle with mental health issues or mental illness really don't have, they have the legal age they are, but their emotional age might be much less, and they still need a great deal of help from their families and from their caregivers. So it does become really quite a big problem to get help. So I do think that the government's saying they're going to focus on it. I think we need to build out really strong policies around this area so that we can have a handoff, and certainly I'd like to be at the table to make sure when my daughter's the one being handed off that it's a strong system.
That's a good point, because have you had the conversation with your daughter and told her that when she turns 18, technically mommy's not allowed to see, your files anymore, but obviously you'll still be interested?
Yes, well, we haven't had that conversation as yet, but we like to leave some surprises for the rest. And certainly at 18, she's going to be a different person than she is at 14. At 14, I think she recognizes very clearly she needs all this support. But at 18, it's going to be a different conversation, I would expect.
Marg, do we know what percentage of children who suffer from mental health issues as children carry those issues into adulthood as well?
I actually don't know that number.
70%.
70%?
Yes,
Okay, that's right.
70% of children who have mental health issues in adulthood started when they were a child. So it only goes to, remember your question about, identifying kids in the school year too early. Actually, I'm not sure that there is, any barrier to that, because if we can catch these kids early, give them the right interventions, then we're not going to see them in the youth justice system or in the social service system for the rest of their lives. So again, a strong investment.
Anybody listening?
I hope so.
You hope so. I want to thank the three of you for coming in tonight and setting the table for the discussion that is still to come about all of this. Kimberly Moran, Children's Mental Health Ontario; Marg Campbell, Delisle Youth Services; Lori Spadorcia, love that last name, Center for Addiction and Mental Health, CAMH. Thanks so much for visiting us at TVO tonight.
Thanks for your interest.
Up next, we've looked at the past 3 years. Now we're going to broaden the conversation and look at the next 3 years, right after this. Three years down, 3 to go. Ontario is setting out on the next 3 years of its mental health strategy. And joining us now for more on the programs, the funding, and the rollout, Susan Piggott, Chair of the Ontario Mental Health and Addictions Leadership Advisory Council; Steve Lurie, Executive Director of the Canadian Mental Health Association's Toronto branch; and Lana Fredo, Executive Director of Sound Time Support Services. That's a community mental health agency. As I welcome the three of you to our discussion as well, we want to remind everybody that if they want to weigh in on Twitter, #AgendaTVO, and join the conversation if you will. We played a clip earlier in the program of Eric Hoskins, the Minister of Health and Long-Term Care. Let's do that again as we set up this discussion. Roll tape, please.
14 ministries have come together to develop this plan. It's probably unprecedented, and an unprecedented example of ministries working hand in hand. And it's a plan that I believe will provide better access, better quality, and better value. And to help guide the implementation of this plan, I'm very pleased to announce today that a new Mental Health and Addictions Leadership Advisory Council has been created. And this is a council that will provide advice on the strategy's investments. It will promote collaboration across sectors, and it will report annually on the strategy's progress.
Okay, that council he's referring to is you and your colleagues, of course. What did he tell you when he met with you that he wanted from you?
He told me that he was committed to making a difference, to mental health and addiction services for people in Ontario, and that he believed that he needed advice in terms of reaching his goal, and he wanted the council to provide him with advice, and he also wanted the council to report out annually to the people of Ontario so they could be assured that progress was being made. That's
Who's on the
what he said.
council?
The council, it's a council of 20 people from across the province, across a number of sectors. We've got people from the criminal justice system, from education, healthcare, community services. We have 2 people who reflect the Aboriginal point of view. We've got people who work with children's mental health, the adult system. There are frontline providers. There are people who are running community agencies. We have a couple of psychiatrists. I think that the ministries have done a pretty good job in trying to have a sector that is representative of many different interests.
Okay. How much time is the minister giving you to come up with the plan?
Well, we have a 3-year assignment, which is really quite unprecedented. We have 3 years. We're going to meet 3 times a year. We may have to meet more often, but right now that's what's envisioned. And we may have to have a number of work groups, depending on the complexity of some of the issues.
I don't know if you've heard this criticism, but I've heard this criticism. Too much CAMH representation on your council. True or false?
I think there is the impression that there's a lot of CAMH representation because there are a number of people on the council who have at one time in their lives worked at CAMH. But when you consider that CAMH is the largest mental health and addiction facility in the country, it's not unusual that people like me, who's a nurse and a social worker, who spent most of my career in the community, just completed 7 years at CAMH. Gail Zukar is another person who was at CAMH for a while. I take that point. I've heard other people say it, and we'll have to make very sure that this is a very diverse council reflecting a lot of points of view.
You're not one of those people who sort of likes to go along to get along, right? Like you're a bit of a blank disturber. Is that fair to say?
I probably have a reputation of being a polite blank disturber, yes.
So when he asked you to do this job, I presume at some point you said to him, you know, I'm not going to sugarcoat this. You're going to get it.
What I tried to indicate is that this annual report is going to be a real annual report based on proper indicators that are going to mean something to the people in the community. You asked the group you were meeting with just before to comment on whether the families and clients of the system would have noticed any of the changes that the service providers have noticed, and they said no, in the main not. Mm-hmm. So we have to come up with indicators that are going to be meaningful to the service users, and we will report out fairly every year to Ontarians as to what improvements are being made in the minds of the users of the system.
Okay, one more question before I get your colleagues involved, and that is, Eric Hoskin said in that clip that there are going to be 14 government ministries involved in all of this. That's a lot. How come?
Well, it's because people who are living with serious mental illness touch down in a number of different government departments, whether it's people who are looking for housing, people who are involved with the criminal justice system, people who are in and out of the education system, people using community services. The responsibility for the delivery of a lot of these supports is spread across many ministries. The other one is Ministry of Community and Social Services, which of course has responsibility for our Ontario Disability Pension Program. This is a huge issue for many people living with serious mental illness. So we need to have all these ministries. I'll just add, Steve, that it's particularly significant in my mind that our council is going to be working at the same time as there's a government commitment to poverty reduction. Deb Matthews has that file. Provincial government commitment to long-term affordable housing strategy, and also the ongoing commitment to accessibility for Ontarians with disabilities. So this is actually an unprecedented time of focus on this file, and if we can't make some real significant steps in 3 years, we should be ashamed of ourselves at the end of the 3 years.
Okay, Steve Lurie, let me bring you into the conversation here and ask, what do you think the most important thing that this council, and then by extension the government, has to address?
I think it has to address the capacity gaps in the system, similar to the discussions you had previously. The fact is, in Toronto, if you need supportive housing, there are 8,900 people on the wait list. You can wait 3 to 5 years to get a place to live. That's unacceptable. And we know from the work that the Mental Health Commission did on at-home chez soi that having flexible supports and a place to live makes a tremendous difference. You don't show up in emergency departments, you don't show up in hospital, you're less involved in the justice system. So there's got to be a big push on housing. I think the other thing is that the Mental Health Commission recommended that all jurisdictions in the country aim for a 9% target of health spending in relation to how much they spend on mental health. We're at about 5%. So we need a lot more on the ground, and those wait lists, whether it's children or adult, won't decline unless more money's put in.
Lana, what would you add to that list of what you think the top priority ought to be?
Well, I applaud the systematic approach with this plan. However, I've been around long enough to see several other attempts at planning and revisioning the mental health system.
So can I just understand, do you go in therefore a bit skeptical? A lot skeptical?
Yes, and I should add the caveat that the community agency for which I work, and we are unique in that all the people who work there, we are users and former users of mental health and addiction services. So we're more of a canary in the coal mine kind of role than a regular mainstream mental health agency. So I guess, I have no objection to these pillars or any other pillars or plans or anything else, but what it comes down to is the implementation. And we have never had a plan that gets really systematically into the weeds of how we're going to implement all of this. We can't object to any of these things that are articulated in the pillars. However, the reality is, in community mental health, for example, we've been collecting data for many years. We have no mechanism to connect that data either to each other or to produce. We have no one who is charged with interpreting the results. And so we actually don't know how many people are using mental health services. We actually don't have a mechanism to figure out what it is precisely they need or what is happening to them. That's only one aspect of the implementation that falls flat.
You talked about pillars, and let's just bring up this list if we can here, Sheldon, of what the main pillars in the government's approach that it has identified will entail: promoting mental health and well-being, ensuring early identification and intervention, expanding housing, employment supports, and diversion and transitions from the justice system, providing the right care at the right time in the right place, and funding based on need and quality. Those are the 5 pillars as identified by the Ministry of Health and Long-Term Care earlier this month. Okay, let's go through these. Susan, when they talk about promoting mental health and well-being, that sounds like a very general catch-all. What's that supposed to mean?
What it really means is health promotion. And we're already seeing a lot of this going on now. A lot of universities and schools and workplaces are actively engaging in discussions with the people in their institutions about the importance of talking about mental illness and addiction. So that's what that is. Okay. And I would say that work in that area is well underway. It's actually probably what's resulting in more people coming forward looking for help with their problems.
Steve, ensuring early identification and intervention. What's referred to there?
Well, that's programs that in particular target young people, and we've actually had a great success in Ontario. About 8,000 people every year are served by early psychosis programs, and 70% of them are able to either continue in school, live successfully with their family, get their own place if that's what they want to do. So that is certainly, for young people, it's an important pillar that builds on the previous initiative in the mental health strategy. I think it also means that if you show up in your family physician's office and you've got a mental health problem, you'll be directed to the right kind of help. So for example, rather than being prescribed something, if you're suffering from mild to moderate depression or anxiety, you might be directed to a program called Bounce Back that they've been operating in BC that helps people learn how to cope with the anxiety and the depression without having to use medication, and it's been highly effective.
Lana, in your experience, is there too much sort of automatic prescribing of medication, not enough? When I say in your experience, I don't mean just you. I mean, you know, in your broad experience of, you know, other people that you've watched go through this system as well. Is there too much of that and not enough of the other kinds of programs or services that might be more effective?
Well, yes, that goes without saying. However, even in the sense of other programs and services that might be more effective, I mean, you have to think about it. Mental health is the only area of healthcare where we're basically working with models that are 30 years old. Case management, ACT, supportive housing, all of those models are at least 30 years old. What area of healthcare are we working in that kind of environment? We are very reluctant to take any risks, to try anything new, to do anything innovative. We have people who use mental health services and their families who are entirely unhappy with the service that they're getting. However, there doesn't seem any, you know, what we say is if all you have is case management to offer, then every problem looks like a case management problem.
Right. Okay, but if you were going to suggest one innovation then, that might be different from the way they've been doing it for the last 30 years, what might that be?
We have a lot of success among consumer groups working with access to employment. That is, you know, we have streets to homes. We have also streets to jobs, right, where people aren't forced to go through these, you know, the complicated ODSP employment process or any of these programs that result in people with mental health and addictions issue either being underemployed, or in the case of people with serious mental health issues, I mean, our unemployment rate is still 85 to 90%. That has not improved in all the time that I've been working in mental health.
Steve, would you agree that a lot of the, what did you call them, the processes that are in place are 30 years old, they're badly out of date?
Models.
Models, the models.
Well,
badly
I actually would agree partially, because I think some of the implementation has been flawed. For example, in case management, based on what's just come out of the Mental Health Commission, intensive case management for homeless people, which keeps them connected to their community and living in housing and getting jobs. You should be spending $6,500 a person. We spend about $2,000. So we often underserve, and then we say, well, case management can solve everything, and it can't. There was recently a consensus conference in Alberta that the Institute of Health Economics had, and they've looked worldwide. And if these types of interventions, community treatment teams, flexible ACT services, intensive case management, employment, peer support are implemented the way the research evidence says they should be implemented, you actually do see major reductions in hospitalization, major reductions in unemployment, major reductions in homelessness. But what we've done, as a colleague from Ireland said, that we suffer from implementation deficit disorder. We have a lot of grand plans, but we don't actually use the evidence we've got to implement things successfully and to, as Lana says, tweak the things that we know aren't working that well.
But if you need $6,500 per person and you're getting $2,000, your implementation schemes can be brought down from heaven. It's not going to work. Is that fair to say?
Yeah, I mean, and part of it is recognizing, for example, the $82 million that's been projected by the minister, which first time mental health actually got mentioned in a budget, so we're happy for that. But that's 1/16 of what we spend annually on healthcare in this province. So the question is, what is it going to take to meet the targets set by the Mental Health Commission? Or if you don't believe the Mental Health Commission, the WHO says that countries who are spending 9% of their health spending on mental health have GDPs of $22,000 per person. In Canada, we're at $44,000, so it's hard to argue we can't invest more and invest it, as Lana says, more effectively.
Is it a money problem as far as you can tell?
It's partly a money problem. However, I'm of the opinion that we need to take a really good look at what we're spending now and what we've got and how effective is it. and I'm not averse to putting more money into the system, of course. However, I'm not so sure that some of the things that we're investing in now are worth the money.
Like what?
Well, take supportive housing, for example. Certainly, I'm not anti-supportive housing. I'm not anti-housing. We need more housing. However, the mental health system is very good at building the front door when they actually build something, but they're not very good at building the back door. So, for example, if I were poor and was in need of supportive housing, I would get into my supportive housing. Now, eventually. Now, in order to leave my support, if I no longer needed the supports in my housing, I would have to leave my housing, take my chances in getting into, for example, here in Toronto community housing, where the wait list is 20 years. So even though I'm doing better, I feel I don't necessarily. Why would I?
Why would I? You can't make the next step.
And we don't have mechanisms in the system to help people transition out of more intensive services to less intensive services.
Okay. Steve, quick word on this, and then I want to get through the rest of
that's
this.
where, picking up on what the provincial auditor said 4 years ago, that we need at least 23,000 more supportive housing units and using rent supplements and housing allowances, because if you had a housing allowance at, let's say, $7,000 a person, which is the gap between what the social assistant rates and the market rent is, people could take that with them, and when, as Lana said, they didn't need the high level of support, they could move and get another apartment in the community. And in fact, if we made a commitment to meet the auditor's target of 23,000 units over the next 6 years, that would cost $182 million and leverage billions of dollars in new construction and more affordable housing for people. So that's a notion of spending smarter.
Gotcha. Okay, Susan, back to you. Providing the right care at the right time in the right place. That's another one of the pillars. What do they mean by that?
That's really what you were talking about earlier with Kim and with Lori, when they talk about the need for there to be better collaboration between hospitals and community services, between community services themselves, better understanding of people's needs. As Lana said, there are people who get stuck in certain parts of the system when they're ready to move on, and the system's just not flexible enough to allow them to move on. This one is really heavy lifting, but on this one you've got the local integrated health networks are working on it, the new Health Links program. There's no shortage of attention being paid to try to improve the services for people with mental health and addiction. The mystery, and we were talking about this a bit earlier, is why is it proving to be so difficult?
Do you know the answer to that?
I don't know the answer to that, but I'm determined that we're going to make some progress on this.
Okay, next pillar, funding based on need and quality. Means what?
That one is somewhat related to the point I just made. We fund things basically the same way now that we have forever. And yet there are significant population changes in this provinces. There are parts of the province that are much more heavily populated now than they used to be before. There are also better intelligence about what kinds of services are actually high quality and work and have good results. The funding doesn't necessarily respond to these kinds of changes, or it hasn't necessarily. So again, this is a very, very complex area, and I'm envisioning that the council's going to have a special work group looking at this. But it actually is a companion piece to the fourth strategy around service coordination.
Let's put the elephant in the room here right on the table right now, which is, you all know there's a $12.5 billion deficit in the province of Ontario right now. And you also know that the province is determined to hold the line on healthcare spending. And what did you say? It's 1/16 of the healthcare budget right now. And they want to hold health spending, not like in past years where it would go up 6, 7, 8% a year, but to 1 or 2%. They want to cut other ministry spending. They want to cut 6% out of the Ministry of the Attorney General, and on and on and on. How are you going to get the kind of money that you say you need to do the improvements that you say are necessary in this financial climate? Steve.
Well, I think one of the things we need to do is recognize that out of the $18.5 billion that the government invested in the last 10 years in healthcare, they allocated $400 million to mental health. Other jurisdictions on a per capita basis, New Zealand, which is a lot smaller than Ontario, in the same period invested $198 per capita on mental health. We invested $16.47.
Okay, there's no question, you've made the point that we're not spending as much as other countries in the world. However, what are you going to do? I mean, you're going to tell the doctors not to set this guy's broken leg so we can use the money for health care, for mental health?
Well, first of all, I think the suggestions that I've made and others have made would lead to a modest increase. I mean, 1/3 of 1% still gives you 1.7% to increase healthcare spending. So some of this is setting a priority to say, for the next 3 to 6 years, mental health funding is going to have more of a priority in terms of growth in health spending than it's had previously. The other area, and I know the provincial government is trying to get a better deal from the federal government, and it seems to me, and CMHA has made a decision to try and convene that kind of conversation across the country to say, since provinces didn't invest in mental health, and you've got the Mental Health Commission's target of 9%, we may need a dedicated fund for another period of time to allow the right kinds of investments, as Lana and Susan have talked about, to be made in mental health systems. Because if we don't invest the money, the Mental Health Commission did a paper called Making the Case for Investment in Mental Health. It costs us $50 billion a year in terms of the Canadian economy, directly and indirectly, because we don't do mental health right.
So a better investment on the front end obviously will pay off in the long run.
We're going to pay for it. It's $100,000 to keep somebody in a hostel for a year. It's $140,000 to keep somebody in a jail. One admission costs $8,000 to $12,000, where that amount of money spent in the community can support a person for a year.
Okay, but Susan, here's the thing. I know you know this. Stephen Harper and Kathleen Wynne aren't speaking.
Yes.
So there's a bit of a problem in terms of Steve's scenario of the federal government deciding to pony up more money in transferring it to the province of Ontario to help pay for this. It seems like the money we have is the money we have. So what's the better alternative?
You're suggesting the council try and do something about the relationship between the federal and provincial.
I'm just putting it out there.
The council's going to work with the money that we have been told that the province is willing to invest over the next 3 years, and try and make sure that those investments have the intended outcomes.
But you can embarrass them into ponying up more.
I wouldn't put it so much in terms of embarrassment, but there is no question that over 3 years we should be able to do enough work in terms of, I'm putting this, sort of using the term loosely, in cleaning up the system, in trying to see how to make the system work better, such that we're able to determine the real amount of money that's needed. In other words, right now you have a lot of people who will say there's plenty of money going into the system, it's just not properly coordinated, it's not working well, it's not being effectively invested. If we can devote ourselves to trying to look at service coordination and effective service, and still there are waiting lists and still there are gaps in service, then it's going to be pretty clear that it's a financial investment issue in the main.
Lana, what do you see?
Well, first of all, I think that there can be some realignment within, I don't know if I would use the term cleaning up, even I wouldn't say
Well, I
that.
don't, as soon as
You know
I
what she
said
meant.
the word, that's why I
That's
said
something people would expect me to say.
Yeah, well, I just, yeah.
You knew what you meant.
Realigning.
like that.
You're so much more politic than I am.
Yes.
I like the way you're keeping it real, though. I like that. Okay.
It's a role reversal. So yes, realigning some of the existing things we're doing in mental health. I do find it interesting that we only talk about people with mental health and addiction issues using mental health and addiction services, because actually we do use the rest of the healthcare system as well.
Sure.
And we sometimes, because of the lack of support in mental health and addictions, we make those other services very expensive as well. And no one really talks about that. We're sort of cleaved off to one sector of the healthcare system.
But the thinking that somehow we're going to start spending a whole lot less money on acute care and take that money and put it into mental health services, I mean, there's a political agenda behind those dollars as well.
I don't think that's going to happen.
Right.
So I'm pragmatic in that respect. So I mean, all I can, I work with what I have, right? I see myself primarily as an advocate, so I can conveniently ignore that fact and say, without blinking, that people with social disabilities, mental health, addictions, developmental, intellectual disabilities, we have a right to health care like any other Ontarian. So that's my party line. Realistically, I know that we aren't going to be getting that much more money. And so all we can do is work to make the existing services we have far more. I believe there's a lot of room for improvement. They could be far more effective than they are.
20 seconds left. Where do you want to see this in 3 years' time?
I would like to be able to see the third annual report be something that Ontarians can look at and say they really, really have made some significant progress in terms of waiting lists, both for service, for supportive housing. I think it's possible, but that's what we're going to aim for.
Gotcha. Thanks to the three of you for coming in tonight and helping us out with this. Steve Lurie from the Canadian Mental Health Association, Lana Fredo, Sound Time Support Services, and Susan Piggott, Mental Health and Addictions Leadership Advisory Council. Thanks for coming to TVO tonight.
Thanks for doing the show.
Thanks.
Support Ontario's public television. Donate at tvo.org.